My name is Pat Iyer. Welcome to Legal Nurse Podcast. This is a show in which I bring to you legal nurse consultants and other business experts to talk about some of the issues that affect you as a legal nurse consultant in your analysis of medical records. A big factor in many nursing malpractice cases in particular is issues related to policies and procedures, nursing administration, and some of those nuances of training people to manage the care of complex patients. Dianna Goodwin is with me this morning. She is a registered nurse with 28 years of experience, and she has extensive experience in management, medical surgical, telemetry, critical care, and nursing support specialties. Dianna, welcome to the show.
Good morning, Pat. Thank you so much for having me.
I was just reading a story last night, Dianna, about nurses who are striking in New York City over the quality of care, short staffing, the stresses and the pressures associated with being a nurse in acute care today, of course, not limited to acute care in terms of stresses. Let's focus on your role as an administrator, or the role of the administrator in managing nurses in an era that we are dealing with right now. We are recording this in the beginning of 2023, and we are still focused with huge hospital beds being, huge numbers of hospital beds being utilized for acutely ill people in hospitals across the country. From your perspective, working in this world, what are some of the things that you see as challenges?
Well, the big one is staffing, is having enough nurses or ancillary help to support those nurses in providing care to the high number of patients that we see every day in our facilities. And part of the problem with staffing is, you think that you post a position, for example, and you get applicants to that position, and that you can pick all of them and bring them into your facility as a staff member. But there are some issues around that people may not realize that can become problematic as you move forward with training them and having them practice. And some of those issues are having qualified candidates. And what I mean by qualified is that nurse needs to have 2 or more years of experience and also have competencies around the equipment, procedures, processes that we do in that department. So, for example, in the critical care unit, a lot of times critical care areas have a cardiac focus, and they don't always see a lot of cardiac patients. They may admit patients post MI, or they do angioplasty or short procedures, but there are things like the balloon pump, for example, where we manage a patient who has heart failure and needs some that support, and that nurse has to be able to be competent in managing that piece of equipment. That is a low frequency, high risk piece of equipment that requires it to be managed in such a way that sustains that patient's life until we can get them either surgery or some type of intervention, or through their crisis, whether it's congestive heart failure. But you need to make sure that when you're hiring staff and you're hiring into a specialty area, that you're thinking about those aspects of the nurse that you're hiring. So it's tempting to bring a nurse on that has experience. It would be tempting for an employer to hire me, for example, with 28 years of nursing experience. What they need to remember, though, is those 28 years, I practiced 6 years ago at the bedside, and I have not taken care of a patient for a long time that's had a balloon pump. So those are some of the challenges that I see that we face now, because it takes about 90 days to recruit an experienced nurse, another 45 to onboard them and train them.
Let's
and that
break
can
that
be
down a little bit, Dianna, because you brought up some things that have sparked my curiosity. You mentioned about looking for somebody with 2 years of experience. What are your thoughts about the challenges of hiring new graduates into a hospital? And a second question, would you hire a new graduate to come in to work in the critical care unit?
Yeah, so new graduates are a different bring up a different issue in the legal aspect of things, right? Like new grads, there's typically a structure around how we onboard them. So it doesn't matter how much experience the new grad has, because you can hire a nurse and they're considered a new grad up to the first year that they've been a nurse, they've been registered as a nurse. So I have a structured program that I would bring my new grad into, meaning that they come into a program that's typically anywhere from 9 to 12 months long. They are with a preceptor, and new grad programs vary across the country, but ones I've seen that work really well are that you stagger their orientation over the course of that 9 to 12 months, and you have them with a preceptor. You meet with them regularly. You make sure they get the orientation that they need. And I would never expect a new grad to take care of a patient that is on that balloon pump all by themselves, like I mentioned earlier. So yes, we do hire new grads into the critical care area, and they typically get about 6 months of orientation. They are not with a preceptor all the time during 6 months, but they go through classes. Once they're on their own, they are paired with somebody else who has experience, so that you make sure that they have a buddy next to them that they can rely upon. And that poses a challenge when we're hiring. I can't hire, if I have 20 open positions, I can't hire 15 new grads. I have to, and that's why I mentioned one of the challenges being hiring qualified candidates. You need to have a mix of nurses that are present on your unit at any given time, a mix of skill level. You need to have seasoned nurses as well as your new nurses. And you have to make sure that you have that when we're talking about like a balancing act, right? You want to make sure that you're leveraged with more seasoned nurses than you are experienced. But that's a challenge in today's world that I think that all hospitals are facing, that we have more unexperienced applicants or experienced nurses with lower levels of experience than we do with higher experience.
Thank you. And something else that you mentioned sparked me to ask you another question. The high risk, low frequency phrase that you identified, can you explain to our viewer what that means in case they're not familiar with that matrix?
Yeah, so oftentimes in the work that we do as nurses, that we encounter a procedure or a process or a medication that we don't use as often. So that would be the low frequency part of that. An example I gave was the balloon pump, and that is only in certain areas. There are units where they have balloon pumps every day, but there are critical care areas that don't see those very often. Out on the tele-med surge floors, an example of low frequency could be in an area where they don't have a urology service, but a doctor needs to implement bladder irrigation on a patient. That would be a low frequency for that particular department, but it's a high risk intervention. You're hanging fluid. You have to make sure that the fluid is running through the catheter and that the urine is coming out on the other side, and that things balance out, that what you put in is what comes out. and that it is doing its job of removing the clots from the catheter. Things like heparin infusions are another low frequency, high risk. I hope that it helps explain it.
Sure. I watched a fascinating video about a week ago in which a fireman was applying this concept to going into fighting fires or running into burning buildings. The low frequency events, but then they become high risk to the firemen. And I had only heard of this matrix applied to healthcare before. So I was thinking about how it applies to many things that we do, that we don't do them very often, but if we don't do them correctly, we could end up injuring ourselves or injuring other people.
Mm-hmm.
Let's shift and focus on what you talked about in terms of the training and the orientation. This is an area that I spent some time in when I finished my master's degree program. I can remember, Dianna, when I graduated from my master's program in 1979, that orientation and training was completely different at that time. The hospital who hired me had a one-day orientation program. And by the time I left that job 7 years later, we had put together a multi-week orientation and a full preceptor program that helped people in a much more comprehensive way. Why is it so important that training be given to get a person off on the right foot? Before we continue with the show, I'd like to share this special announcement with you. Is subcontracting for you? Whether you're a new LNC looking for experience or a busy LNC with a growing practice, my book, LNC Subcontracting: How to Boost Your Business, will answer your most urgent questions about subcontracting. In 1989, I got a phone call that changed my life. The attorney asked me, "Can you review my emergency department case?" I responded that I didn't take ER cases, but I had a colleague who worked in the emergency department as a clinical specialist. I connected the attorney and the expert, and I realized I could expand my business by supplying experts. I did expand my LNC business to include subcontracting. By the time I sold my company in 2015, I had 200 experts with a range of backgrounds under contract, including nurses, doctors, pharmacists, radiology technicians, physical therapists, occupational therapists, social workers, nutritionists, and other healthcare providers. The quantity and quality of these experts made my business highly saleable. Going beyond my extensive experience in this field, I collected information from both subcontractors and employers. You'll read in my book their personal insiders' perspectives on the benefits and drawbacks of subcontracting. This book is for you if you desire the experience and skill you'll gain when a legal nurse consultant shows you the ropes. You need to know how you can have positive experiences on either side of the subcontracting relationship. You want to hire subcontractors, but don't know how to find, evaluate, and mentor them. Or you're wondering if you should bring subcontractors into your company. My book, LNC Subcontracting: How to Boost Your Business, will give you the answers you need. In my book, I provide practical assistance to both subcontractors and employees. I cover what you should look for in a subcontractor, how to shine as a subcontractor, what questions you should ask your potential employer, and what the IRS says about subcontracting, and much more. Regardless of what your particular interest in subcontracting may be, you need my book, LNC Subcontracting: How to Boost Your Business, to help you make a decision. Buy it now. It will help you build an empowered future. Go to this link, lnc.tips/creating series. Now let's return to the show.
I think one of the first things is about safety, is making sure that that nurse is competent to provide safe nursing care to your group of patients. And every hospital is unique in how they operate when it comes to the types of services they provide, to the way that they staff and their skill mix on the unit, their policies and procedures. So it is very, very important that you have an orientation program that acclimates that nurse to your facility. If you don't provide the proper orientation, then as an administrator or a manager, you are placing yourself in a position of liability. While I am not liable for the negligent actions of a nurse, I am liable for making sure that that nurse has the training that they need to operate safely. I am also liable to make sure that I supervise that nurse in their practice of nursing and to assess whether or not they need additional training or competencies to provide safe nursing care.
So much responsibility on the administrators, the supervisors, and the educators. When medical malpractice cases arise involving nurses, there are often questions about what was the background of that nurse, who was available to supervise that nurse, how did that error occur, was that nurse taught to perform that skill properly, did anyone verify that they were indeed safe? One of the things that we did when I was in charge of staff development was validate people's medication administration skills by making sure that they were supervised with a checklist, and somebody had to observe them making medication rounds to ensure that they could follow the steps. And every year there were a few people who we had to weed out because they couldn't safely perform all of those steps under supervision. Those were difficult conversations. I remember my vice president of nursing would recommend that they go to a nursing home to practice instead of dealing with the intensity of hospitals. Now that advice would not be appropriate. I don't know if it was appropriate back then, because nursing homes have even less supervision and resources available for registered nurses, and the pace certainly today is not slow. Let's focus on training employees on how they can communicate their safety concerns or issues. First of all, why is it so important that nurses know how to communicate when they think that there's a concerning change in a patient's condition, for example?
Well, nurses need to know that it's okay to speak up and to say what's on their mind about patient care. It's so important for patient safety. For that's the big reason, is patient safety, is what it boils down to, is being able to take care of the patient in a way that helps to get the patient out of the hospital and back home. That's our goal for every patient. And nurses need to know how to escalate any concerns that they may have. And it's important to role play that, to practice that, to remind them of that on an ongoing basis, because they tend to sometimes forget or hesitate, especially when it comes to dealing with physicians. You have a doctor who tells you to do something that in your mind or in your gut even you feel isn't right. And you say to the doctor, you want me to do this? I'm sorry, but I don't think that is the right thing to do. It is so hard for nurses to be able to say that, because the doctors have more education than us most of the time, right? And they have more experience in dealing with these things every day. But the nurse also needs to know that what our gut is telling us oftentimes is the right thing. And even if it is just to say, okay, can we pause for a minute and check before I move forward with doing what you asked? And if the doctor says, no, do it now, then the nurse has to know what my next step is. I'm going to go to my charge nurse, right? I'm going to say to my charge nurse, the doctor wants me to do this. What do you think? And hopefully the charge nurse agrees with you and says, no, let's check on that, and tells the doctor, we're going to check before we move forward. And if the charge nurse says, oh, no, we do that all the time, or, just do what the doctor says, then the nurse has to know it's the supervisor or the manager that they need to go to next. If they're not reachable, if it's the middle of the night and they're not there, the nursing supervisor, if you can't get their attention, then you would move up to your chief nurse executive. And from there, they should be able to help you to get to the chief medical examiner or, chief medical officer, if that's who you need to go to. So teaching the nurse to follow the chain of command, and that it's okay. I tell my staff all the time, I'm not perfect. If you don't agree with me, that's okay. If you can't get me to see your point of view, please go above me. Here's my supervisor. And if they don't listen, here's their supervisor. We deal in patient lives, we deal with patients' lives. And if you don't teach that to your staff, then you're doing your patients a huge disservice.
And what you're describing, Dianna, is so scary for the nurse in that situation, who may question herself or realize that she's going to be creating a lot of waves by doing that. I hope that the number of occasions where that's necessary have been limited in your experience, that before it goes all the way up, somebody along the line says, wait a minute, she's right, or he's right. We can't do that. Have you encountered many situations where that type of questioning has occurred?
Yes, I've actually experienced something myself. I worked on a trauma unit, and I had gone into work. I was a clinician, so I wasn't a manager, but I was an assistant nurse manager. I'd gone in on a Saturday to check on something, and a nurse comes running down the hallway saying, I am so glad you're here. And she had a patient who had been involved in a motor vehicle accident, had alcohol on board. His alcohol level when he came in was over the limit. He was what we term intoxicated. And of course, we admit these patients. He wasn't injured. He had no injuries, but there's a process that you go through in trauma to make sure that your patient doesn't have any injuries. And he hadn't followed that process. He had gotten out of bed. He took his collar off. And he was upset because he had somewhere he had to be. And because he had come in with alcohol on board, the physician didn't want to take his word for the fact that he had a job that he had to get to. And his parents were there, and they were going to take him to his job. It was about his livelihood. And the doctor wanted to put the patient back into bed and restrain the patient. 4-point restraints to get him to stay put until the trauma doctors could come around and clear him from his C-collar and clear him to be able to get up and move around and all of those types of things. And I said, absolutely not. Security is standing outside the door waiting to go in and restrain this patient. And I spoke with the patient, determined that to me, he had sound mind. He was no longer intoxicated, and that he had a plan in place that sounded safe to me. And I hadn't assessed this patient other than the verbal conversation that I had with him. And I went back out and told security, please leave. It was only causing the patient to be upset. The doctor was very upset because she's telling security, no, restrain him. I pulled the doctor to the nurse's station and said, "I'm sorry, but we are not going to restrain this patient." And her attitude was, "I'm the doctor and you're going to do as I say." So I picked up the phone and called the lead trauma doctor. I didn't have to talk to my manager or anybody. I just jumped right to the chief of the department and called him and said, "Can you please come right away? I have a situation." And he, because of our trust that we had developed, he came right away and said, "Absolutely not. We are not restraining this patient." And, and he, and inappropriately, I think, in front of everybody, basically told the doctor that, that is never a good thing to do. And that when the nurse is telling you that this isn't the right plan, that you listen. And and it was one of those situations where the doctor, actually, she had called the house supervisor, and as I'm on the phone with the lead doctor, she's on the phone with the house supervisor saying that I have a nurse here who's being insubordinate. So that created a whole other can of worms, I guess. And the trauma doctor, seeing the house supervisor, come up and was talking with me, and he came over and he said, "If you write this young lady up for insubordination," he said, "I'm going to tear it up. She absolutely did the right thing in getting between this physician and the patient to protect him." I just imagine if I hadn't been there, though, Pat, that poor patient would have been put in 4-point restraints, because the nurse at the bedside was beside herself. And then the doctor was very, very much so adamant about what was going to happen. She felt the right thing to do for the patient.
So what was your relationship with the doctor after this incident?
I pulled her into my office, and we sat for a few minutes and talked about what happened. We debriefed each other, how I could have handled the situation better, how she could have handled the situation better. She took ownership of the fact that she was being insistent and aggressive in her treatment style. I think she took to heart what the doctor told her and embarrassing her in front of everybody. We talked a little bit about that, and I encouraged her to speak with him privately, because it's never good to breach those types of things publicly. But we had a good relationship. It really is about communication and being open to feedback, because taking ownership of your part in the issue is also very important, and not saying, "No, I didn't do anything wrong," because in the heat of the moment, we're doing things to make sure that the patient stays safe. And you're trying to manage that professionally sometimes can be challenging.
What a situation, Dianna. It was a power play, a game of who's going to have more authority in the situation. And I see this team lining up and this team lining up, and the two teams going head to head. And then the trauma doctor saying, "But I'm the one who's in charge here, and I will tear up that complaint," because she was advocating on behalf of the best interests of the patients. Well, it certainly gave the young man and his parents a different view of healthcare from that experience.
Yeah.
What do you mean they would have tied me down in bed with leather restraints on my legs? I have to go to my job. Oh, interesting. Well, Dianna, I know that our listener is going to want to know how they can get in touch with you. I know that you provide services as a legal nurse consultant and could be an expert in reviewing cases involving nursing supervision and administration. So let's find out how would be the best way to reach you.
Well, my profile on LinkedIn is Dianna Goodwin, very simple. My email address is dlgoodwinlnc@gmail.com. And I can also be reached by phone. My area code is 724-322-1171.
And there are two N's in Dianna's name, Dianna. Goodwin is Goodwin. Dianna, thank you for sharing your expertise with us this morning. I have a feeling that we could talk war stories for several hours, but we won't. And I appreciate you sharing your expertise and your story with us this morning.
Thank you so much for having me.
You are welcome. And for our viewer, be sure to go to legalnursebusiness.com. Check out what's new on our website. We have a section called New Editions of upcoming programs, conferences, courses. That's your go-to on what is occurring in the legalnursebusiness.com world. Thanks so much, and come back for the next show. Hi, I am Pat Iyer with Legal Nurse Podcast. Coming up next, you're going to have an opportunity to hear a story about what happened in an ICU called Mount Carmel, and a physician named Dr. Hussel and a group of critical care nurses who were asked to carry out orders that you will hear are shocking in the amount of medication that the doctor ordered. Erin is my guest. Erin is a legal nurse consultant and critical care nurse who is involved in looking at these cases from the standpoint of what the nursing responsibilities should have been. So, Erin, I'd like you to give our viewer a quick overview of the topic of your podcast.
Sure. So the Mount Carmel and Dr. Hussel litigation happened in Ohio. We started with 40 cases, and it got narrowed down to a criminal trial, 10 civil suits, and it involved nursing, physician, and pharmaceutical negligence. It's a pretty interesting story about large amounts of medication given at end of life.
And you will learn more about how Erin analyzed these cases, what materials were available to her as a legal nurse consultant, and how it turned out. I am sure that you're going to appreciate the complexity of this case, and perhaps will give you a different perspective on how something that on the surface is so wrong becomes so right in the minds of the nurses who were asked to do things by Dr. Hussel in the end-of-life care of patients on ventilators. Stay tuned to Legal Nurse Podcast to find out about this case and the LNC's role in helping to analyze the liability of the nurses.